Disseminated intravascular coagulation, or DIC, is a serious bleeding and thrombotic disorder that results from abnormally initiated and accelerated clotting. Subsequent decreases in clotting factors and platelets ensue, which may lead to uncontrollable hemorrhage. The term DIC can be misleading, suggests that the blood is only clotting. However, there is profuse bleeding that results from aggregation of platelets and clotting factors. DIC is always caused by an underlying disease or condition. That underlying problem must be treated for the DIC to resolve. So DIC is not a disease. It's an abnormal response to the normal clotting cascade stimulated by a disease process or disorder. The diseases and disorders known to predispose a patient to DIC are listed in Table 30.19 in your textbook. DIC can occur as an acute catastrophic condition, or it may exist at a subacute or chronic level. The condition may have one or multiple triggering mechanisms to start the clotting cascade. For example, tumors and traumatized or necrotic tissue release tumor factors into circulation. Endotoxin from gram-negative bacteria activates several steps in the clotting cascade. Tissue factor is released at the site of tissue injury and by some cancers, such as leukemia, and enhances normal coagulation mechanisms. Abundant intravascular thrombin, the most powerful coagulant, is made. It catalyzes the conversion of fibrinogen to fibrin and enhances platelet aggregation. There is widespread fibrin and platelet deposition in the capillaries and arterioles, resulting in thrombus. This process can lead to multi-organ failure. In addition, clotting inhibitory mechanisms such as antithrombin 3 and protein C are depressed. Excess clotting activates the fibrinolytic system, which in turn breaks down the newly formed clot, creating fibrin split products or FSPs. These products have anticoagulant properties and inhibit normal blood clotting. As FSPs accumulate and clotting factors are depleted, the blood loses its ability to clot. A stable clot cannot be formed at injury sites, which predisposes the patient to hemorrhage. Chronic and subacute with long-standing illnesses such as cancer or autoimmune disease. Occasionally these patients have subclinical disease manifested only by laboratory abnormalities. However, clinical spectrum ranges from easy bruising to hemorrhage and from hypercoagulability to thrombus. DIC has bleeding and thrombotic manifestations. Multiple factors cause bleeding manifestations in DIC. They result from consumption and depletion of platelets and coagulation factors, as well as clot lysis and formation of FSPs that have an anticoagulant property. Bleeding in a person with no history or obvious cause should be questioned because it may be one of the first manifestations of acute DIC. Bleeding manifestations include manifestations in the skin, such as pallor, petechiae, purpura, oozing blood, venipuncture site bleeding, hemoptysis, and occult hemorrhage. In the respiratory system, we see tachypnea, hemoptysis, and orthopnea. In the cardiovascular system, we see things such as tachycardia and hypotension. The GI tract shows both upper and lower GI bleeding, abdominal distension, and bloody stools. In the urinary tract, we'll see hematuria. The neurological system will show vision changes, dizziness, headache, mental status changes, and lastly, in the musculoskeletal system, we might see bone and joint pain. Thrombus manifestations are a result of fibrin or platelet deposition in the microvasculature. These manifestations affect first the skin, showing cyanosis, ischemic tissue necrosis, and hemorrhagic necrosis. Secondly, the respiratory system showing tachypnea, dyspnea, pulmonary emboli, and acute respiratory distress syndrome. In the cardiovascular system, we see EKG changes and venous distension. The GI tract shows abdominal pain or paralytic ileus, and kidney damage shows as oliguria, leading to renal failure. This slide shows the events that happen during the process of DIC. This slide shows gangrene secondary to severe DIC. Tests to diagnose acute DIC are listed in Table 30.20. As more clots are made in the body, more breakdown products from fibrin. Again, these are termed fibrin split products, or FSPs, and they interfere with blood coagulation by 1. Coating the platelets and interfering with platelet function, 2. Interfering with thrombin and thus disrupting coagulation. And 3. Attaching to fibrinogen, which interferes with the polymerization process necessary to form a stable clot. D-dimer, a polymer resulting from the breakdown of fibrin, not fibrinogen, is a specific marker for the degree of fibrinolysis. In general, tests that measure raw materials needed for coagulation, such as platelets and fibrinogen, are reduced, and values that measure clotting times are prolonged. Fragmented RBCs, indicative of partial occlusion of small vessels by fibrin thrombi, may be found on blood smears. It's important to diagnose DIC quickly, stabilize the patient with oxygen and volume replacement, treat the underlying causative disease or problem, and control thrombus and bleeding. Depending on its severity, a variety of methods are used to manage DIC. First, if chronic DIC is diagnosed in a patient who's not bleeding, no therapy for DIC is needed. Treatment of the underlying disease may be enough to reverse the DIC, such as chemotherapy when DIC is caused by cancer. Second, when the patient with DIC is bleeding, therapy is directed toward providing support with needed blood products while treating the primary disorder. Blood products are given cautiously based on specific component deficiencies to patients who have serious bleeding, are at high risk for bleeding, or require invasive procedures. Blood products cryoprecipitate in fresh frozen plasma, or FFP, is usually reserved for a patient with a life-threatening hemorrhage. Therapy stabilizes a patient, prevents extravasation or massive thrombus, and permits institution of definitive therapy to treat the underlying cause. Cryoprecipitate replaces factor VIII and fibrinogen, and the fibrinogen level is below 100 milligrams per deciliter. FFP, or fresh frozen plasma, is given only to patients with significant bleeding and a prolonged PT and APTT. It replaces all clotting factors except platelets and is a source of antithrombin. A patient with thrombosis is often treated with anticoagulation with heparin or low molecular weight heparin. Heparin is used in the treatment of DIC only when the benefit, reducing clotting, outweighs the risk, further bleeding. Antithrombin 3 may be useful in fulminative DIC, although it increases the risk of bleeding. Chronic DIC does not respond to oral anticoagulants. It is controlled with long-term use of heparin. Be alert to the development of DIC, especially with the precipitating factors listed in Table 30.19. Remember that because DIC is caused by an underlying disease, the problem must be managed while providing supportive care for the manifestations of DIC. Appropriate nursing interventions are essential to the survival of the patient with acute DIC. Astute ongoing assessment, active attention to manifestations of DIC, and prompt administration of prescribed therapies are crucial. Early detection of bleeding and clotting, both occult and overt, must be a primary goal. Assess for signs of external bleeding such as petechiae or oozing at an IV site or an injection site. We want to look for signs of internal bleeding such as increased heart rate, changes in mental status, increased abdominal girth or pain, and any signs that microemboli may be causing clinically significant organ damage, such as decreased renal output. Minimize tissue damage and protect the patient from sources of bleeding. Give blood products and medications